Hello, everyone, and welcome to the Strength and Hormones podcast. I am so excited to be joined by Dr. G today. She's an expert in endometriosis, and we're going to be talking all about endo and natural treatment options and just really every question you guys have asked about endometriosis, because I know I've gotten a ton about them. This is actually our first podcast that we've ever done on endometriosis.
Wow.
Yeah.
I'm honored.
Yes. So hopefully this will really cover like a breadth of information for people that are dealing with endometriosis and also give them some hope as to next steps of where they can explore. So thank you so much for being here. I'm really excited.
Oh, thank you for having me.
Yeah, of course. Maybe you can just start off by providing us just a brief intro of yourself.
Yeah. So I'm a naturopathic doctor licensed in California. I'm also certified in functional medicine. So I have three roles, really. One is in clinical practice, where I have my own practice in Northern California. I primarily see patients who are seeking a functional medicine approach to endometriosis, fertility, or really any type of bothersome period symptoms. And then I also work on the medical education team at the Institute for Functional Medicine, where we curate medical education presentations to help spread the word about functional medicine and teach other healthcare practitioners worldwide. And then I also do some independent consulting for some supplement companies.
Amazing. Wonderful. So tell us a little bit about just endometriosis in general. Like, what is it? And then what is the diagnostic criteria for how someone gets diagnosed endo?
Right. So endometriosis is a chronic, systemic inflammatory condition that is not treatable. It is characterized by tissue that is very similar to the tissue lining the inside of the uterus that grows outside of the uterus. The diagnostic criteria is really to have laparoscopic surgery where they're actually able to sample the tissue, biopsy, and confirm that it's that similar tissue that we use to diagnose endometriosis. But we're slowly making advances in regards to how specific we can be with imaging techniques, and there are no current biomarker lab tests that we can do to diagnose endometriosis, but we're getting closer.
Mm-hmm. Yeah. And I think one of the big problems with endometriosis, right, is that so many people struggle for many years before a diagnosis actually occurs.
Right.
Would you say that that's because the only way for diagnosis is through laparoscopic procedures, or is there something that like we're missing in the conventional model to be able to pick up that endo's happening?
Yeah, I think it's a great question. So I think there's several prongs to why it's so long. And when we say many years, we're talking like 7 to 12 years. So we're talking a decade really of wondering and trying to find an answer to the question. So I'd say it starts with just symptom recognition, right? When it comes to periods, we normalize a lot of the symptoms because there's such variety amongst every person that menstruates. And so we're all kind of checking in with each other to see what's considered extreme. And we're all kind of normalizing a lot of those symptoms. So I think it really starts there. And that's based on a lot of social pressures, I think, to say, it's just a period. It shouldn't be that painful. Just take some Tylenol and, right, it's going to happen every month. So you kind of have to figure out how to manage it. And then once it gets to the point that you actually feel motivated enough to actually talk to a healthcare provider, then you're met with a little bit of gaslighting. And then I would say, a lack of awareness and knowledge to actually recognize that there's something deeper going on. So whether you're going to the emergency room, your OB-GYN, or your primary care physician, that is the opportunity for your doctor to then recognize and then set you on the path towards diagnosis, whether that's follow-up imaging or surgery. So once you have those two barriers where people are normalizing your symptoms, and then you're also being met with healthcare providers that are also normalizing your symptoms, that can cause people to then extend how long they're actually waiting to get diagnosed.
Sure. Yeah. And what exactly is that line of these are normal period symptoms? Like, yeah, you probably have some PMS and there's probably some things going on there that could be addressed, but they're maybe hormonal, more inflammation driven, right? Versus this is endometriosis and you need to advocate for yourself for your doctor who maybe isn't quite giving you that referral.
Right. The line for me is very clear in that if it's bothersome to you at all, it requires further investigation. So pain is usually the most characteristic symptom that people will seek help for. So whether that's pain with your menstrual cycle or around your menstrual cycle, pain with sex, pain with passing bowel movements, but there's a lot of patients that I have that don't have any pain. And really the only symptom or sign that they may have endometriosis is they've gone several months or several cycles of trying to get pregnant and have been unable to. Another common symptom that I'll see is just fatigue and really strong mood symptoms or fluctuations. And a lot of times symptoms can be masked because we're put on birth control at a really early age, usually for other reasons. I usually commonly see it for acne, or if your mood changes when you first start menstruating are really extreme. Oftentimes, a lot of my patients would have been on some type of oral contraceptive pill for about those 10 years, right? So usually around the ages of 13 to 15. And then once they start to enter college in their early 20s, by that time, they've already been on oral contraceptive pills for a really long time. And a lot of patients find some relief with that. And so then you can see that we have this disease that's slowly developing over time, but we're not really doing anything to treat it or manage it specifically because we've done such a good job at masking the symptoms for the time being. So it's a lot of that history taking that I think is the line for me, where how did we get to where you are today in regards to how your periods have started to control your life? And depending on how that conversation goes is how we talk about if endometriosis is part of the picture.
I see. Okay. But the true way of diagnosis would then be through laparoscopic surgery. And so I'm sure you're seeing patients that both like haven't had laparoscopic surgery and just maybe presume that maybe they have endo, right? And
Right.
then patients that have been diagnosed with endometriosis. Is that correct?
That is correct.
Yeah.
And sometimes I'll even have patients that have had imaging done, because usually if you have some sort of menstrual cramping or pelvic pain, the next line or step in diagnosis would be to just even get you a pelvic ultrasound to see if there's some other possible causes to why the pain may be happening. And sometimes we'll see an endometrioma or an ovarian cyst that is due to endometrial growth, and that can be diagnostic of endometriosis. Sometimes during an actual physical exam, you can start to feel some distortions in the anatomy, or that things are just not as slippery and movable once you do a pelvic exam. If there's some type of adhesions there, that's usually a pretty good indication that there may be endometriosis present.
Sure. Okay. And what are some of the common drivers? Do we know what causes endometriosis?
I wish that we did, because that would make, I think, everyone's job and lives so much easier. But I like to think of it as being kind of a conglomeration of a lot of factors that contribute to how endometriosis forms. I'd say the main contributing factor, I don't know that it's an initial driver, is really a hormonal imbalance. And we tend to think about estrogen dominance being really characteristic of endometriosis. But really, there's two parts to that, right? Is estrogen just too high and it's dominating all the other hormones? Or do we just not have enough progesterone around, and estrogen is actually at a normal level, so we just don't have enough to balance it? And really, the third part to that is really estrogen metabolites. So I have a lot of patients whose estrogen levels look fine, but once we look at the metabolites, we can say, okay, you're actually producing more of the pro-inflammatory estrogens, which may be contributing to endometriosis. So the second part of that is really inflammation. And inflammation is really an immune system response at its root. So I think about those two things concurrently. And really, when you have lesions outside of your body that are responsive to your cyclical hormonal changes that are building up, just like your endometrial lining, and then shedding and bleeding, just like your endometrial lining happens during your menstrual cycle in a period, that shedding and the growth that's happening outside can really trigger an inflammatory response. And then you get stuck in this cycle of chronic inflammation. So we have hormonal drivers, we have an immune system driver with inflammation. And then because endometriosis can affect all parts of the body system, once we start to affect those other body systems, then we start to contribute to this environment where endometriosis has this really friendly environment to keep growing and developing. So if it starts to affect the liver, then we're not able to detoxify as well. If it starts to affect the GI tract, then we have a whole slew of problems in regards to nutrition and how you're absorbing your nutrients and how well we can utilize things like food if your gut is just not in a good place. And so I'd say those are the three primary drivers that I tend to think about. And then when we start to think about the mental emotional side and the toll that this condition can take, especially once we start to incorporate things like fertility challenges, that can really be a barrier to how well people can respond to the therapies that we're really trying to use to manage endometriosis.
Sure. Okay. And so you mentioned inflammation. With that, do you typically see like an elevated C-reactive protein? Are you seeing like high levels of oxidative stress that are occurring in endometriosis? Are those clinical indicators that people could have tested?
Though they are clinical indicators that they can have tested, but it's not an ace in the hole that it's always going to be elevated. So I always do some counseling with patients that just because we test CRP or ESR as a way to assess for inflammation. Just because they're not high doesn't necessarily mean that there's no inflammation going on in the body. And when you go into the science behind how quickly those markers rise and how quickly they decline and what they actually respond to in regards to inflammation, you can start to explain to them why there may be nuances there. But there's still tests that I run regularly because it's still something that you want to address, meaning that if your CRP is really high, even above 3, it's still something that you want to make sure that you address and see if it's monitoring or responding to the therapies that you're using.
And do you feel like a high estrogen state is what drives the cell growth that causes endometriosis, or is it more so that the endometriosis creates this hormonal imbalance?
It's both. And this is going to be a common answer for a lot of endo questions just because it's so unique per person. But so estrogen is a driver of endometriosis. We know that estrogen can contribute to things like angiogenesis, which is a huge contributing factor to how those lesions can really establish their home in wherever they decide to migrate to in your body. And angiogenesis is really just the bringing of blood vessels towards the lesions so they can actually get their own source of nutrients. And what that does is it also allows them to distribute the estrogen that those lesions are actually producing themselves. So there's an enzyme called aromatase, which is responsible for converting testosterone to estrogen. Those lesions actually have some aromatase activity themselves, and so can actually contribute to the estrogen dominance picture or produce estrogen themselves. So it's a little bit twofold where they're responding to estrogen, but they're also contributing to that estrogen dominance picture as well.
And is progesterone typically something that you see also as helping to be able to reduce pain or helping to be able to reduce this growth that's happening with endometriosis?
It depends. I would say 85% of the time in my patients, progesterone can be really useful for things like pain. I tend to use it a lot in patients who are also trying to get pregnant. You obviously have to be very mindful of the dosing with fertility because you don't want to be preventing ovulation. So you want to make sure that you're dosing any oral progesterone after they're ovulating or after their LH surge. But progesterone is a really great therapeutic for endometriosis because it hits a lot of those targets. So it gets converted into allopregnenolone, which can have really, really amazing benefits in regards to just calming down the nervous system. And endometriosis lesions actually encourage nerve growth towards them. And with the increased pain signaling, that's how you can eventually walk your way towards something called central sensitization, where your pain and your nervous system is just a little hypersensitive to things. So the progesterone helps to kind of offset that. And then we're also addressing the hormonal piece. And progesterone also has some anti-inflammatory effects. So there's a lot of those 3 root cause drivers that we talked about earlier that I use progesterone for. And then depending on what the goals are, whether it's fertility or just to manage pain, we may play around with the form that we use. So I will prescribe oral progesterone cream, or we will even use intravaginal progesterone depending on what the patient's needs are.
What about someone who's trying to maybe get their progesterone up naturally? Do you find that to have the same effect on the endometriosis pain if someone is able to increase the progesterone naturally, or do you find with endometriosis, typically those patients have difficulty with getting progesterone levels up?
That's a great question. I guess it depends on why the progesterone is low.
Yeah.
So I think with progesterone, it's really tricky. Sometimes it's not always a level issue. And when we start to think about why progesterone is produced in the first place, which is really from that corpus luteum or the remnant from an ovulated, after ovulation, if that progesterone level is high, then we really have to figure out if you're even ovulating and that's why the progesterone is low, because then we may work a little bit more upstream where we're stimulating your pituitary to signal your ovaries to make sure that you're actually getting to ovulation and getting that progesterone rise. Oftentimes we'll use something like chasteberry, or we'll address a lot more of the mental emotional stress factors to help encourage progesterone. The other part to that is the progesterone signaling, or something called progesterone resistance, which is really when progesterone is not able to bind to its receptor appropriately. So there's actually appropriate amounts of progesterone around, it's just not doing its job effectively. That's really tricky to address because as you start to dive into the research, you start to learn that it's a little bit more closely tied to your genetics and something called microRNAs, or little RNAs that can bind to those receptors and block progesterone from doing its job appropriately. That can sometimes require you to push progesterone at a much higher dose. So I know of some fertility doctors that will even do injectable progesterone to just kind of oversaturate those receptors in a way. But I would say that the goal is not necessarily to raise your progesterone levels, but I want my patients to have predictable cycles. So that way their lives can become a lot more predictable, because with endometriosis, there's just so much, I would say, chaos that happens with that condition, because things and flare-ups can happen at any time. So I'd say the stability and the predictability of progesterone is really what the goal is, versus trying to get it to a certain level.
Mm-hmm.
Now, if they're not ovulating and we're worked upstream and they're still not getting to where they're able to ovulate, then we may give progesterone in the luteal phase just to encourage the rebalancing of the hormones during the luteal phase after their supposed day of ovulation.
Sure. Okay. And is there like an average age of onset? Like, how do we know how many years someone has to be in a high estrogen, potentially low progesterone state for endometriosis to develop? Like, is this something that maybe we can predict they've been dealing with since they were a teen from their first menstrual cycle?
Right. I think it goes back even further. So if
Yeah.
we really think about the fact that the egg, or who you are today, is an egg that was within your grandmother's body, when you start to think about all the hormonal exposures and xenobiotics and stress that you've been exposed to for now 2 generations, I'd say it depends, right? If you have this family history where both of your maternal grandma and your mother had difficulties getting pregnant, they maybe were on birth control because they had really heavy, painful periods, then I'd say, right, your likelihood of onset is probably a little bit earlier because your exposures have been a little bit earlier. Sure. If, let's say, you happen to be the first generation that has endometriosis, then your onset may be a little bit later, but I'm a really strong believer that epigenetics plays a really strong role in endometriosis, which is why I really think getting ahead of this condition and being more aware of it allows you to set your future generations up for success, right? Mm-hmm. Because we're thinking about ourselves, but we're also thinking about our future children and their grandchildren. If we know how the longevity really of what these lifestyle changes can really make an impact. So
Sure. Yeah. Okay. And you mentioned before about the role of inflammation with endometriosis. And I feel like there's been a lot of newer information coming out about endometriosis kind of functioning as an autoimmune type disease. What are your thoughts on that? And do you think that for someone that is experiencing endometriosis that has maybe addressed things hormonally, the immune system is another avenue that needs to be addressed?
I think absolutely. The immune system is now being stressed in this chronic inflammatory environment. So I actually think of endometriosis more closely akin to cancer, even though it's considered a benign disease. There are a lot of similarities with autoimmunity, meaning that there is a dysfunction of the immune system in what you are tagging as being foreign, in how quickly you're able to get rid of debris or those things that you're trying to tag as being foreign, and then how quickly you can shut down the inflammation, right? I think of inflammation in 2 phases. One is like the fire truck that puts out the fire, but they don't do anything to clean up the debris. There's a second phase to inflammation called the resolution phase, where you actually clean up everything and you tell everybody to calm down, and we don't need to have this really strong inflammatory response. That is the part that you really want to address to help make sure that you're decreasing your risk of developing autoimmunity. Because we know about autoimmunity is it's this development until you get to an eventual trigger that switches your immune system to recognize self as foreign. Mm-hmm. The reason why I think about it more closely to cancer is because we have these added elements of encouraging blood vessel growth, and we actually have an increased number of growth factors that are abnormally responding, which can contribute to the growth of those lesions. So that, I would say, is where I tend to categorize endometriosis, and why it's so important to me that once you have the diagnosis, even if you have surgery, it's really important to implement long-term management strategies because of the way that we know that this disease develops over time.
Yeah, and so many people have surgery and then end up having to have more and more surgeries. So it really isn't a cure, right? It's kind of a Band-Aid.
Yep.
So that's great to hear that there's some other avenues and I know like the gut is another component, right?
Yes.
So I'm sure there's work you do with patients in that area too.
Absolutely. Yeah. When things are so painful that, you are almost passing out when you're sitting on the toilet, and you think about how we encourage people to have bowel movements regularly every day, that will really shift the person's behavior and what they're eating, right?
Mhm.
Because they'll say, okay, I don't want to eat as much because I actually don't have time to have a flare on the toilet today. And then you start to notice this degeneration of eating habits because they're trying to protect how often they're in pain. And so getting the gut in a really good place where they're able to have easy to pass, well-formed bowel movements every day while still eating freely is the goal. And ultimately, you want to get the gut in a good place so you can prioritize things like food. Because when you're paying for surgery and supplements and fertility treatments, and you're already 10 to 12 years into your diagnosis, you have to be really, really careful with how you're spending your resources, both energy, time, and money.
Mhm.
And so being able to utilize food as a way to help address things like inflammation, hormonal imbalances, and support a balanced immune system, you have to address the gut first. That is a foundational part of a management plan.
Yeah, and if there's this estrogen dominance, I'm sure that if they're not going to the bathroom, that's only exacerbating the hormonal imbalance that's driving the endo even further, right? So it's
Exactly.
this continuous cycle that's being perpetuated.
Exactly. And what's so cool about phytonutrients is really when we think about things like quercetin and resveratrol and other phytonutrients that we're trying to get from food, the real therapeutic benefit comes from how your microbes in your gut are actually metabolizing those phytonutrients and releasing them into your bloodstream. So it's actually the only way that you can get a lot of those benefits that we talk about so often from food.
Sure. Okay. And with a lot of the information you've talked about regarding how endometriosis can drive infertility, are you finding in a lot of your patients that when they're able to address things through a functional medicine model, that they're able to conceive with endometriosis, or once they've already had these endometrial lesions occur, they have to have surgery in order for fertility to be an option?
Yeah, it depends. So it's very different per patient. I am never discouraging patients away from surgery. And the real reason is because the research shows that with surgery, and because we know that the severity of your disease is not always correlated with how severe your symptoms are, it's really a timing game, right? If you are really set on getting pregnant within the next 6 months, but your symptoms are so severe that you're taking Tylenol and aspirin around the clock, you're missing work, we have to get you in for surgery, right? Even if we were to get you pregnant, the state that your body is in right now is not even very conducive to having a child or conceiving, right? We're talking about increased inflammation, usually, right? All of those hormonal drivers that we talked about earlier. If the symptoms are not as severe, right, we've done all of the tests where we don't see any cysts. We know that you're ovulating regularly. The fallopian tubes are open. You haven't tried getting pregnant and haven't had any issues with miscarriages. We may try to get pregnant naturally before we explore surgery. But I would say symptoms and the impact on my patients' lives are usually the main drivers for getting them into surgery sooner than later. The back end of surgery and really the post-op care is really where we start to hit the ground running, because usually most surgeons will say we want you to get pregnant within the first 6 months is usually our like golden window, especially if you're coming in with really severe symptoms. So the goal is to do all of the things that we're doing to address endometriosis, which is going to set you up for success with surgery, right? We don't want your inflammation to be really high. We want your hormones to be fairly predictable and well balanced. And we want your immune system to be very resistant as you're going into surgery. That's going to help with your recovery on the back end. And so what we're seeing is I see my patients usually recover in less than a week. They're usually back to work within a couple weeks. And I'm talking like stage 4, stage 5 endometriosis. And then within about 6 to 12 months, usually patients are getting pregnant depending on how aggressive they want to be, right?
Mhm.
It's really just dependent on what their goals are and what their timeline is. So I'm very lucky that I have very dedicated patients, but that's usually a result of them being discounted for so long. So they're
Course.
coming prepared and ready to take action in all the ways.
Yeah. And do you see that with patients that have endo that get pregnant, that they are dealing with more complications generally during pregnancy?
That's a great question. I wouldn't say during pregnancy, But there is a lot of my patients express a lot of anxiety once they
Sure.
actually give birth, right? Because a lot of times they feel the best that they've ever felt when they're pregnant and even while they're breastfeeding. So when you're breastfeeding, your prolactin is really high because you're lactating. That's going to calm down your hormones that are talking to your ovaries. So you get this like kind of tranquil period, which is beautiful because you get to just focus on being a mom. But then as you start to talk about weaning off of breastfeeding, a lot of my patients will start to get a little bit more anxiety about their cycles returning. They'll get one kind of crampy cycle. So I would say less complications during pregnancy and a little bit more concern as we start to come off and wean off of breastfeeding and return to normal cycles.
So beautiful though that can be such like a relief
Oh,
period for, I mean, at least a year,
I
right?
know.
If not
I'm
even
like,
longer.
if you're like, thank goodness we could give you this time where you
Yeah,
can just enjoy being a mom and you don't have to worry about anything else.
of course.
So the longer that we can extend that is always the goal.
Absolutely.
The only caveat I would say to that is if we're not addressing anything before you get pregnant and we have some underlying really severe metabolic issues, inflammation, maybe some underlying cardiovascular issues, because we know that preeclampsia can contribute to some pregnancy complications, then we can start to be concerned about what concerns they have. As a naturopathic doctor, I'm not allowed to manage people who are pregnant in California. So that's usually when our journey will pause and they'll go continue care with their OB. But after that was when we pick back up.
Yeah, of course. Okay. And I want to talk a little bit about some options for pain management,
Mhm.
maybe some like supplement and herbal type options that are more natural approaches outside of just surgery as the only solution. What are some of those common supplements and herbs that you're using for patients?
Right. I use PEA a lot, which is a derivative of omega-3 and omega-6 fatty acids. PEA are those fats that you naturally produce in your body for that second phase of inflammation, so the cleanup or the resolution phase. I will use those quite often because those tend to be depleted when you're in a chronic inflammatory state. The way that I equate it to patients is your cleanup crew just can't keep up with all the little mini fires that are being put out. So you're giving it a little bit of extra support. And then it depends on where the pain is coming from, right? If you're having pain with bowel movements, then we may focus a little bit more on things like fiber, hydration, magnesium citrate. If it's more muscular issues, then we may focus on something like magnesium glycinate and magnesium malate. If it tends to be more inflammatory, that's when we'll lean more heavily on omega-3 fats, more of the antioxidants, the PEA. So we tailor the treatment plans depending on what the main characteristics are of the pain. And then when we start to talk about medications, really progesterone has been really helpful for a lot of my patients with chronic pelvic pain specifically, especially if it's due to endolesions. And then LDN has been something that I use. So low dose naltrexone is really useful in regards to its ability to promote endorphin release. And then it also has some benefits for balancing your immune system. That will be something that I will use only if we've tried everything else and the pain is really severe and my patient can't get surgery for whatever reason, which happens more often than what I would like to happen. But it's one of those medications where I tend to think of it as being a little bit of a Band-Aid, right? Because we are just telling your body to be less painful or have less of those pain signals. But until we really address the anatomy and the lesions, the pain will always be there. So that's one of those medications where there's a lot of counseling around it, and we want to make sure that we're still addressing the root cause. And then if we don't do any supplements or any medications, then I'm a huge proponent of acupuncture, pelvic floor physical therapy, castor oil packs, TENS machines, if that's indicated for you. I like the Ovira. So I like using all the things. And I like knowing what people use because depending on what is helpful for you managing pain gives me some indication as what the cause may be. So I have a lot of patients that take Tylenol and ibuprofen that say it doesn't touch the pain for them at all. So because we know how those medications work, then we know that it might be due to some type of anatomical or muscular issue. Yeah.
Okay. And are there any type of herbal or natural options for breaking up lesions? I know I've heard of like using enzymes before to be able to do so. Is that something you're currently using in practice, or is there other options out there for patients?
Yeah, adhesions are really tricky. And the really tricky thing about endometriosis is we are trying to control processes that we don't actually want to turn off all the way. So that's one of the hardest things about the conventional medical therapy is that you are trying to shut down estrogen, but we know that that's a critical hormone for so many parts of our body and our physiologic systems for the rest of our lives. And the same thing applies to adhesions. So it's not actually something that you want to turn off completely, right? Because that's part of your healing process, especially after surgery. Things like wobenzyme and bromelain are really helpful. Obviously, you just want to counsel that you take them away from food because they're also digestive enzymes. So once you take them away from food, they're able to digest some of that fibrotic tissue. I'll be honest though, I don't see it be super effective. What I mostly encourage patients to do is do castor oil, just gentle rubs once they've been cleared by their surgeon, because really that making sure that the tissue doesn't stay stuck on top of each other is really how those adhesions form. So I think the combination of those two things is what is helpful, and I think that applies to all of endo management is you have to do a little bit of topical physical medicine care on top of the internal supplements, medication, diet care.
And what are your thoughts on using something like N-acetylcysteine or glutathione? I know there's been some good research on the role of that in endometriosis.
I love NAC. I think it's a great supplement to take for a lot of reasons, especially endometriomas. NAC is an antioxidant and it's a precursor for glutathione. So I'd say usually if the cost is of a concern, figure out why you're taking it. If you have an endometrioma, I'm probably going to have you prioritize NAC, which isn't very expensive. And if we're more concerned about antioxidant support, then I may just have you go straight to glutathione. But I think both of those things are really great. I also like things like quercetin and resveratrol. And I tend to promote a lot of the more antioxidant support through food because I think that's a much easier way to get it in. And I think it's a much more enjoyable way to take those supplements because otherwise you have to kind of nitpick all these different supplements. And for a comprehensive antioxidant support, you're going to add about, 2 to 7 supplements to your regimen if you allow yourself.
Yeah, there's so many different antioxidants that are out there, right?
Yeah.
So yeah, you could really be going crazy. I mean, glutathione is one of my personal favorites. I feel like if there's one antioxidant to prefer out of all of them to prioritize, it's that, right?
Totally. Yep. And I always prefer the liposomal form too.
Totally. Yeah.
Yep.
We have a podcast episode for anyone that's listening that was a few episodes before this will release on glutathione and like how to support glutathione recycling and all of the nutrients that go into that. So definitely check that out if you're wondering why we're talking about glutathione or what that is. Amazing. Okay. And then just like a couple labs that you recommend for endo. I know we've talked a little bit about the hormonal imbalance that can be at play, immune system, gut. What are some typical like labs that you love to run?
Yeah, I utilize a lot of foundational labs that patients have already had done by their primary care provider. So there's some good research to support that we can gain some indications that there may be inflammation or some immune dysfunction just using a CBC and your lipid panel. So comparing things like neutrophils and lymphocytes to your HDL cholesterol is something that I'll do. I'll look at thyroid if there's some concerns about hair loss, dry skin, weight management, energy. But really the main focus is really to see if there's inflammation. So things like CRP, ESR, sometimes I'll use something like IL-6 if we're really concerned. Sometimes I'll take a look even at an omega check to see what your omega-6 and omega-3 fatty acid status is. And then depending on what the symptoms are, we could really run the gamut of labs. So if there's some metabolic concerns, we'll look at insulin and A1C. If there's some hormonal concerns, if we're looking at patterns, I'll tend to do more dried urine testing. So I actually love the Mira or Anito or any of those at-home fertility monitors. If we just want to see what all of your hormones are doing throughout your cycle, I rarely use something like the Dutch test just because one cycle is not as interesting to me. I really want to see what's happening throughout 3 cycles at least. But if I want to confirm an actual level of a hormone, we'll use serum testing for things like estrogen, LH, FSH, and progesterone, testosterone. And then for the specialty lab tests, it just depends on what the symptoms profile is. I use stool tests fairly rarely. It's really only if I need to rule something out, like a parasite, which is not always 100% true, or if I think that there's SIBO, or if I think that there's some underlying inflammation like IBD going on and I need to check that calprotectin. And then if we want to do even more extensive nutrient testing, we can do something like a NutriVal. So there's really, and I wish I had a protocol for every single patient, but I actually love it because then we can tailor things to what actually would make a difference in our management plan for each person.
Yeah. And I think that's so huge because I know every provider has their own way of doing it. And I kind of do the same thing with patients we work with where we customize it based off the conversation of like what we think that they need. But I know there's lots of other people that just have their normal go-tos, right?
It's easy
But
to, yeah.
it is, but it can get really expensive. And then
Yes.
sometimes you don't need certain things. They're not maybe the priority. And sometimes people get so much testing that it's almost like untreatable because there's so much information and we
It's
can
so
only do
true.
so much at once,
Oh my
right?
gosh. Yes.
So I think it's so important that you have the really important movers, like the big, big boulders, not
Yes.
like the little baby pebble rocks, right?
And I
So,
think patients appreciate that too, right?
Yeah.
And then once you start to ask, they may have already had those tests done.
of course.
And it's just educating them, right? Because they hear a lot of things about these really extensive lab tests that they come in wanting to order. And once you tell them, it's not going to really change what we're doing, then you have saved them $400 to $500 that then they can invest in really good food or going to acupuncture or things that are going to help them on a regular basis. So it makes it exciting. I actually really enjoy it, and it's unique every single time. So yeah.
Wonderful. And you mentioned about the metabolic piece. Is there a link between metabolic health, like insulin resistance, and endometriosis?
I wouldn't say it's like clear cut in the literature yet, but I do see it quite common in my patients. So insulin resistance is really common in something like PCOS, and there is a little bit of overlap between PCOS and endometriosis. But really, when we think about something like chronic inflammation, that is one of the main drivers towards insulin resistance. And then once we start to think about the mental emotional issues and the changing in lifestyle habits from being in a chronic pain, chronic inflammatory condition, there are a lot of changes that people make to their dietary habits just to make it a lot easier for them to get through the, daily activities of life. So it's actually shocking to me how often other providers don't check insulin for a lot of my patients that are trying to get pregnant, have difficulty losing weight, and then also have chronic inflammation like an endometriosis. So I do see a lot of overlap there, and it's frustrating as a provider because that's one of those things that can really turn itself around even within a month. So I absolutely do see a lot of overlap there.
Yeah, interesting. Okay, awesome. Yeah, and I was going to ask you too about that with the PCOS connection. I'm sure there's like a thyroid overlap too that you see. A lot of your patients have endo, also maybe have like thyroid diseases and such.
Yeah, and I think that's the biggest piece that I try to get across to not only patients but other providers as we're building this collaborative care team for our patient is that, okay, yes, we have endometriosis and it's what we consider a female reproductive condition, but you are perpetuating an environment that's inflammatory and with immune dysfunction. So you would be remiss to not be looking at all those other body systems and how they're being affected like that, because we know that no body part is isolated in and of itself and doesn't talk to any other part of your body. So even if we don't see it in the in the literature quite yet, we see it, right, in our patients and how it affects those other body systems on a regular basis.
Yeah. And that's why we have a program called Inflammation Harmony. And that's why we created it, was because I truly believe that if we can address the inflammation, we can address so many of these different hormone imbalances.
Right.
But that's really the first step to start with,
I
right?
agree.
And so that's really where I think a lot of people don't address, because whether they maybe don't have a high CRP or they're not getting tested in that area, and it's not always as apparent that maybe someone's dealing with inflammation because they don't have these like very, symptomatic inflammatory, signs that there's
Totally.
inflammation going on. But I appreciate that that's something that you're doing, that you're really addressing that with patients. Because as you mentioned, it's involved in insulin resistance, PCOS, hypothyroidism, endometriosis, all of these different female health conditions that we see so often.
Right. And fertility, right?
Yeah,
It's going to
yeah.
be one of the best ways that you can support your ability to get pregnant is to create a hospitable environment for
Totally.
conception.
Yeah, absolutely. Well, thank you so much, Dr. G. This was so insightful. Really appreciate all of your knowledge, everything you're doing for your patients. So please tell us where any of our listeners can learn more about your practice and about working with you.
On my website, so dralexisgonzales.com. I'm on Instagram. I think it's X now, Facebook, and LinkedIn. And yeah, I'm here to help as many people as possible. and make sure that people get the clarity and the support that they deserve.
And you're working with patients only in California, or are you working in any other states?
I only see patients in California, but
Okay.
I do offer consulting for those outside of California.
Okay, amazing. We'll put your link to your website and your Instagram as well below.
Awesome.
Thank you so much.
Thank you.